Assalamu alaikum wa rahmatullahi wa barakatuh. Today we will talk about the anti-anginal drugs. And angina or ischemic heart disease, or also called coronary artery disease, describe the same pathological condition. And the most common one is used now is the ischemic heart disease and is considered as the number one killer around the world. Atherosclerotic lesion can occlude the blood flow in coronary arteries, the arteries that supply blood to the myocardial muscle, to the heart, leading to an imbalance between the demanded oxygen and the supplied oxygens. And this imbalance causes what it is called angina. Also, this could happen due to a spasm in the vascular smooth muscles of the coronary arteries or coronary veins. And this leads to reduce the amount of blood that reaches to the heart. So we can take a look here in this one. So when there is a plaque, this plaque is mostly composed of lipid materials such as cholesterol or triglycerides. In addition to there is an inflammatory response due to the accumulation of these materials in the vessel wall. This is called atherosclerotic lesion. And we can see here there is a partial occlusion for the artery that mostly supplied blood to the myocardial muscle. Typical presentation of angina, usually it presents with sudden severe crushing chest pain, and this pain is started from the chest, then radiated to the other parts, such as neck, jaw, back, and arms. It is important to notice that in addition to use anti-anginal drugs for patients with anginal attack, it is important to use or to reduce the risk of other factors such as lifestyle, include smoking, physical activity, or weight management. Besides that, it is also important to change or modify the risk factors or the other concomitant diseases such as hypertension, diabetes, or dyslipidemias. So it is important to put in one hand anti-anginal drugs and on the other hand the other risk factors. Okay, so we have more than one kind of angina, and mainly they are divided into three categories. Number one, stable angina. Number two, unstable. Number three, and prinzmetal angina or variant vasospastic angina. So let's take a look on the figure on the right. So when there is a partial occlusion in the blood vessels, let's say here we have 50% occlusion in the blood vessels. So this could present in the patient without any signs and symptoms, so cannot be diagnosed as anginal patient. However, in the presence of vasospasm of the coronary arteries or the blood vessels that supply blood to the heart. So in addition to the presence of the atherosclerotic lesion, there is a vasospasm. This leads to an increase the obstruction of the blood vessel or the coronary artery and causing severe decrease in the amount of the blood that supply the heart muscle. So at the end, this leads to severe imbalance between the supplied oxygen and the required oxygen. Also, we can imagine this kind could happen by just like vasospasm of the coronary arteries. While it could happen also if there are other factors affecting on the atherosclerotic lesion or the vascular tone, such as exercise or emotional stress. This also could increase the obstruction of the blood vessels, causing increase the severity of the anginal symptoms. So this one, we can consider this one mostly is the stable angina. This one, let's say to make it clear in your mind, this one represents the transmittal angina, and a combination between these two is called unstable angina. Of course, for the treatment here at the end, we can decrease the vasospasm of the blood vessels, and also we can decrease the plaque, I mean the atherosclerotic lesion. This leads to reduce the obstruction in the blood vessels, and this one represents our goal from using anti-anginal drugs. So here is the figure on the right, drugs that are used now to treat angina. You don't have to remember everything in this figure, just to know the many classes. We have around 4 classes, and what are drugs used now for these conditions. So let's start with the first one, stable angina, effort-induced angina, classic or typical angina. They describe the same pathology. They are not different. So when the pattern of chest pain, this pattern of the chest pain doesn't change over the time and also doesn't change by the amount of the exercise or the emotional stress to induce or to predispose an anginal attack. What this means, like over the time, if there's a certain amount of the physical activity or emotional stress induces, this, let's say, the same anginal attack, this called stable angina. So it doesn't change by the physical activity, it doesn't change with the time, it doesn't change with the and the severity of the symptoms. This one considered the most common one, characterized by a pain. It is a short-lasting burning, heavy or squeezing feeling in the chest. The presentation of this kind of angina, either it presents as typical, this pain is a burning, heavy squeezing, or atypical. In the atypical, the patient could have other symptoms other than this pain. They could have like extreme fatigue, nausea, or diaphoresis. On the other hand, they uh, they mm, they could be they could have an angina but without any symptoms. So it is called silent angina. So there is a typical presentation and a typical presentation. Mostly a typical presentation of the stable angina occurs in women, diabetic patient, and elder. This angina causes reduce in the blood flow, or a reduction in the blood flow to the myocardium and a reduction in the oxygen supply to the myocardium. And this causes an imbalance between the supplied oxygen and the demanded oxygen. Typical angina is very responsive to the rest and nitroglycerin, and we will come to nitroglycerin in a minute and discuss this drug as an anti-anginal drug. Then, number two, we have unstable angina. And as we said, it is like, from this figure, it is like a combination between stable angina and transmittal angina. Unstable angina, there is an increase in the frequency, like it happens more, it happens for longer duration, unlike the stable angina for short duration, and an increase in the intensity or the severity over the time. Even the amount of the physical activity or the emotional stress is progressively less than before. So this one is characterized by it is present for more than 20 minutes. In new episode, like in new episodes, it happens like when it is not expected, and also decreasing in the sign and symptoms over the time, or there is just a sudden development of shortness of breath. And all these, let's say, all these features are used now to characterize unstable angina. From stable angina, even the patient could have both. Sometimes they could have stable, sometimes could have unstable angina. So here we have another difference from stable angina. This condition is not treated by rest or nitroglycerin. Unstable angina from a clinical standpoint is considered a form of acute coronary syndrome and require an immediate hospital admission to deal with these symptoms. The third kind, we have transmetal or called variant, vasospastic or rest angina. All these terms describe the same condition. This one is the uncommon one, like unstable angina, more common than transmetal angina. And this one is mostly related to the spasm of the coronary arteries. So even the patient could have atherosclerotic lesion in the coronary arteries, but still the major underlying cause is the spasm of the coronary arteries. So sometimes the patient could have an anginal attack, and this one is not related to the physical activity, heart rate, or blood pressure. It's just due to spasm of the blood vessels in the myocardium. This one also can be treated by using nitroglycerin and calcium channel blockers, unlike unstable angina. Here, there is no place for rest. So because it could happen without any physical activity, as we said here. Then the fourth kind, and this one is considered a little bit is different from the other forms of angina. This one is called acute coronary syndrome. So when there is a atherosclerotic lesion like this one could have a rupture. So atherosclerosis, there is a rupture for atherosclerosis, and after it is rupture, this causes thromboembolic events. So in addition to atherosclerosis, this leads to the thromboembolism, and thromboembolism leads to either a very significant or complete obstruction for the blood flow in the coronary arteries. And this actually leads to the what it is called myocardial infarction and necrosis of the myocardial muscles. And of course, after the necrosis and apoptosis of the cardiac muscles, the myocardium starts to produce certain enzymes as biomarkers for this attack. And these biomarkers include troponin and creatine kinase. So now here we discussed the major forms of angina, and so that we can understand why we describe this drug, not this drug, for which kind of angina. It is important just to identify the best drug for this condition. So, with the treatment strategies, mostly we have four categories of the drugs that are now used to treat angina: beta blockers, calcium channel blockers, organic nitrates, and in addition to one drug in sodium channel blockers, it is called ranolazine. This is the only drug in this category. The major goals from using these drugs, we are trying to increase the blood supply to the myocardial muscle and decrease the workload of the heart, so that we are trying to either reduce blood pressure, reduce venous return, the preload, reduce heart rate, and contractility. So these are the major goals in our treatments. So let's take a look on this figure, similar to what we discussed with the antihypertensive drugs. So when we are choosing anti-anginal drug, we should look to other conditions that the patient could have. Like, for example, we discussed this before with the beta blockers. So if the patient has asthma or COPD, is not recommended to use beta blockers, either avoided or used with caution, while other categories can be used for uh, these patients. Also, if the patient has diabetes mellitus, it is also is not recommended to use beta blockers, and similar to the others, like what the other conditions that the patient could have, it affecting on choosing which anti-anginal drug should be used for this patient. While on this figure, it is just represent a diagram how we treat patients with angina. So when there is stable angina, and as we said earlier in the lecture, in addition to using anti-anginal drugs, it is important to modify other risk factors, such as modify lifestyle, weight, exercise, and modify other co-pathologies such as diabetes, hypertension, etc. So, in the presence of symptoms of angina, the first treatment is starting with sublingual nitroglycerin. It is nitrates. So, after that, after the initial attack, we have to describe beta blockers. And if there is inadequate response for beta blockers, here we have to add either calcium channel blockers or long-acting nitrate. Sublingual nitroglycerin, it is a short-acting nitrate. So with this prescription, so patient could have now beta blockers and calcium channel blockers or beta blockers in addition to long-acting nitrates. Also, if the response is not adequate, here we have to add the sodium channel blocker. It is ranolazine. So this represents the major stream, how to treat patients with angina. Let's start with the beta adrenergic drugs, blockers. We discussed this class of drugs with the antihypertensive drugs, but here we will focus more on the benefits that are expected with using beta blockers in patients with angina. So, beta adrenergic blockers decrease the oxygen demands of the myocardial muscle by blocking all the beta 1 receptors, which presents mostly in the myocardium. Blocking beta 1 in the cardiac muscle decreases the heart rate, contractility, cardiac output, and final blood pressure. So these agents reduce the oxygen demands, and it is very recommended for patients with angina. And this happens during both exertion, exercise, or physical activities, and also during rest. Beta blockers is considered now as the first-line treatment for angina, unless it is contraindicated due to the presence of due to the presence of other comorbidities in the patients. But here there is another exception for using beta blockers in angina. It cannot be used, or it is better not be used for vasospastic angina due to the vasospasm of the coronary arteries. They increase the spasm of the coronary arteries. So from a clinical standpoint, beta blockers are effective in reducing death and MI attack in patients who had a prior MI, and also they improve mortality in patients with heart failure. And we discussed this with anti-heart failure drugs. Also, it's not recommended to use drugs or members of beta blockers that have intrinsic sympathomimetic activity, such as pindolol, because this could worsen the symptoms and could predispose for a second anginal attack. Propranolol is the prototype of this class, but is not necessarily to use non-selective drug for the angina. You can also use more selective drugs such as metoprolol, atenolol. Here it is important to notice with the very high doses, there is no more selection for beta 1 from beta 2. So all drugs now are non-selective. Also, in addition to this, beta blockers should be avoided in patients with either severe bradycardia and patients with asthma. In both these conditions, beta blockers should be avoided. Otherwise, like can be used, beta blockers can be used, but with caution in patients, in diabetic patients, patients with the peripheral vascular disease, and patients with COPD. But here it is highly recommended, so there is a close monitoring for patients. Also, in addition to all these features, we have to remember here that discontinuation or tapered off of beta blockers is not recommended to be done as one step. It is better to be done gradually over 2 to 3 weeks in order to avoid what we call the rebound angina, MI, or hypertension crisis. With calcium channel blockers, so as we discussed with heart failure, calcium is an essential ion, induces both cardiac contractility and cardiac electricity. So by reducing the entrance of calcium to the myocardial muscles, we are controlling these two features of the myocardium. After anginal attack, when there is a necrosis or due to the damage of the myocardium, there is an increase in the influx of calcium to the damaged area. And this actually promotes several other enzymes, such as ATP-consuming enzymes, and this leads to depletion of energy, of stored energy, and worsening ischemia. This is very important to notice during the ischemia, I mean after the either either complete or very significant occlusion of the coronary arteries. So calcium channel blockers protects these tissues, I mean the myocardial muscles and blood vessels that supply blood, coronary arteries to the myocardial muscles. They protect both from the entrance of the calcium. So they induce vasodilator effects in addition to reduce the contractility of the heart muscles and velocity or the heart rate. So we are controlling the blood vessels, we are controlling the heart muscle. So these agents are different. Like some of them are affecting on the peripheral resistance or are affecting on the resistance of the peripheral and coronary arteries, while other members are affecting mostly the heart muscles. So with the drugs that are reducing the peripheral, the resistance of the blood vessels, we are expecting to see reducing the intensity and severity of angina, even with the, let's say, more significant exercise or physical activity. So here, as we said, there are mainly two major classes of calcium channel blockers, dihydropyridine and then dihydropyridine. And these members are different in their selectivity. Some of them are very selective for blood vessels, as with amlodipine, and some of them are very selective to the myocardial muscles, such as verapamil. And diltiazem is an intermediate case between these two drugs. So let's start with dihydropyridine, calcium channel blockers. Here we have amlodipine and nifedipine, and they are different just in the duration of action and the onset of action. So this one has a very minimal effect on the cardiac conduction and function. They are mainly it is mainly acts as potent vasodilator. So this one is very useful for the treatment of variant angina when the main reason for the anginal attack is the vasospasm of the coronary arteries. While nifedipine, it is just different in the onset of action and duration of action. So here it is important to notice that a drug with very fast action and short duration could predispose coronary artery attack. So it is not recommended to use a drug such as nifedipine for patients with angina or at high risk or with angina, because this increases mortality and myocardial infarction or heart attack. Then we have non-dihydropyridine and non-dihydropyridine calcium channel blockers. Here we have mainly two drugs, verapamil and diltiazem. Verapamil, as we say, this drug is more selective to the cardiac muscle, to the myocardial muscles, and it acts mainly on the AV node, reducing the heart rate, contractility, and blood pressure, and finally the oxygen demand. So as we said earlier, this drug is more selective to the myocardial muscles, so it is associated with a greater negative inotropic effect. So it is severely affecting on the contractility of the heart, unlike amlodipine, which is mainly acts as vasodilator. So that verapamil is contraindicated in patients with the pre-existing depressed cardiac function or if there are problems with the AV conduction. With the diltiazem, this drug is also acts on the AV conduction, but it also decreases the rate of firing in the SA node and also induces vasodilator effects on the coronary arteries. So its effects is like a combination between verapamil and amlodipine. Diltiazem can be used for the variant angina, the vasospastic angina, because it causes relaxation of the coronary arteries. It is not recommended to use non-dihydropyridine calcium channel blockers during heart failure because these drugs have negative inotropic effect, and this could worsen the symptoms in this population. Then here we have organic nitrates. Organic nitrate, these compound reduces the oxygen demands through vasodilation effects, and these effects either in the coronary arteries or in the large veins. So let's come here to the mechanism of action. So these drugs, organic nitrates, are converted into nitrite ions and then converted into nitric oxides, and nitric oxides actually activate guanylate cyclase, and this leads to an increase the level of cyclic GMP, and the cyclic GMP causes dephosphorylation of myosin, which is contractile protein, and this leads to relaxation of vascular smooth muscles. So, as we said, nitroglycerin, which is a member of nitrate, it causes relaxation of large veins, and this leads to reduce the preload. It is important to reduce the workload on the heart. But in addition to that, to this effects, nitrates could also induce relaxation of the coronary arteries, and this increases the blood supply to the myocardial muscle. So it is important to notice here their beneficial effects come from two sides, either from the relaxation of the large veins and or relaxations of the coronary arteries. With the pharmacokinetics, the members in this class are different, mainly in the onset of action and the duration of action. So let's see here. So we have mainly three members: nitroglycerin, isosorbate dinitrate, and isosorbate mononitrate. So we can see here with the sublingual or spray when the onset of action, it is around 1 minute, and this is highly recommended for patients during the attack. Unlike if we are using, let's say, oral mononitrate, which needs around 30 minutes, to induce its effects, which is considered a little bit a late response. Sublingual nitroglycerin available either in tablet formulation or spray formulation, as we said, is the drug of choice to promote a relief for an immediate or an anginal attack. Uh, there is an important pharmacokinetic feature for these drugs is the first pass metabolism, which reduces the concentration of these drugs. So it is recommended to use either a sublingual or transdermal route of administration in order to avoid first pass metabolism. Isosorbate mononitrate is considered more stable to the first pass metabolism, so it can be used orally as tablets. While for isosorbate dinitrate, it is just like a combination of two mononitrates. And after first pass metabolism, there is a separation for two mononitrate molecules. With the adverse effects, these drugs are characterized by headache and sometimes a very severe headache due to the vasodilations of the blood vessels in the brain. Also, they could cause postural hypotension, facial flushing, and tachycardia. And all these are related to the vasodilator effects. Phosphodiesterase inhibitors such as sildenafil could potentiate the hypotensive effect of nitrates. So it is important to avoid using a combination of these two drugs on the same time. There is another important feature with the nitrates, what it is called tolerance to the action of nitrates. After a time from using nitrates, there is a phenomena happens in the blood vessels. There is a decrease in the sensitivity of the blood vessels to these drugs. So after using drugs for a while, there is a decrease in the action of the nitrates and vasodilators, or to relieve the anginal attacks. So it is highly recommended to use what it is called nitrate-free interval, like using nitrates for certain time or certain interval time, then discontinue them for another time. What does that mean? Like using nitrates for around 10 to 12 hours, then remove them, like remove the batch or stop using the pills in order to give or to induce the nitrate-free interval. Here it is, but how to choose that time? Like it is important to notice, like angina or variant angina happens mostly in the morning. So we have to choose a time like there is nitrate in the body. So it is recommended to use nitrate or to set the nitrate free interval to a time similar to late afternoon. So that some patients are using their patches for around 12 hours. They remove these patches for another 12 hours in order to restore the effects of nitrates and control this phenomenon. Then finally, we have sodium channel blockers. And here we said like we have only one drug, ronalazine. And this drug is an antiarrhythmic drug, but it also can be used for angina. Improves the oxygen supply to the myocardial muscles. This drug works on the what it is called late sodium channel. And I think we discussed this with very brief description during in the action potential in the lecture of heart failure. So this drug reduces the intracellular sodium and calcium overload. So this drug reduces the workload through reducing the contractility of the heart and also reducing the heart rate by reducing the IV conduction. It seems that this drug is considered like a last choice, as we describe this in the diagram that describe the how to treat angina with the different classes of the drugs. When what I'm talking here is this figure, so it is considered like sorry. So ronalazine is considered like a last choice for patients with angina. This drug seems it is more effective in men more than women, but there is an undefined mechanism for this effect. With the pharmacokinetic, this drug is metabolized by cytochrome 400, 3A, and cytochrome 52D6. So if there are inhibitors, and also it is a substrate for beta glycoprotein. So if there are inhibitors or drugs are affecting on this pathway, this could affect on the level of ronalazine in the patients. In addition, this drug could prolong QT interval, and this is um, happens due to the mechanism of action. So if there are other drugs, it should better to stop or discontinue during using ronalazine. So until here, so we finished the anti-anginal drugs. Please, if you have any questions or comments, just let me know in comment. Thank you very much.